the new definition, the prevalence of hypertension is substantially higher, because according to the previous, it is more than 140, more than 80. But according to the present classification, it is more than 130 and more than 80 millimeters of mercury. Now, let me tell you, when do you call normal, when do we call elevated, and when do we call stage 1 or stage 2 hypertension? Right. Now, this is a very important table which has been given in the Harrison. So, when do you call normal is systolic blood pressure, it should be absolutely less than 120 and diastolic should be less than 80. And when do you call it as the blood pressure elevated? When the systolic blood pressure is in between 120 to 129 and the diastolic blood pressure less than 80, we call it as elevated blood pressure. We don't call it as hypertension, but elevated blood pressure. Then you take stage 1 hypertension. Stage 1 hypertension is that the blood pressure of the individual is more than 130 or equal to 130 up to 139. And diastolic blood pressure 80 to 89. When do you call stage 2 hypertension? Stage 2 hypertension is that when the systolic blood pressure is more than or equal to 140 millimeters of mercury and diastolic blood pressure more than 90 millimeters of mercury. So this is what is the classification of the hypertension in adults, right? Now, let me just compare the same values with the previous classifications, that is JNC 8 and as well as JNC 7. So this is the comparison. So if you take the comparison, so this is what is being given by the AHA, right? That is American Heart Association 2017 guidelines. So according to these guidelines, less than 130 systolic blood pressure and less than 80 diastolic blood pressure, that is considered to be normal. So 130 SBP is cut off and 80 is a DBP being cut off. And whereas you take according to JNC 8, according to the JNC 8, the cutoff is less than 140 by 90. And in elderly individuals, the cutoff, it is less than 150 by 90. Whereas according to American Heart Association, whether it is adults or whether it is elderly individual, the cutoff is less than 130 millimeters of mercury systolic blood pressure. And those individuals who are having comorbidities like coronary artery disease, diabetes and chronic kidney disease, in them, according to the JNC 8, it says the blood pressure should be less than 140 by 90. But according to American Heart Association, what it says is the blood pressure should be less than 130 by 80. So whatever might be the population, either it is adult or elderly individual or with comorbidities, according to American Heart Association 2017 guidelines, the blood pressure should be less than 130 by 80, right? First one is the indications for use of blood pressure lowering medication. Number 2, blood pressure goal for patients with hypertension, right? Third is possible exceptions to the therapeutic goal of less than 130 by 80 millimeters of mercury. So this you need to strictly follow, which has been given by American Heart Association in 2017. Right? And once you start the antihypertensive drugs, there is a considerable variation in individual responses, right? Different classes of antihypertensives have different individual responses, right? And the magnitude of response to any single agent may be limited by activation of the counter-regulatory mechanisms. So different antihypertensives, they have different variable responses. Now, to achieve the goal blood pressure with single antihypertensive, it cannot be done. You need to use minimum of more than or equal to 2 antihypertensive agents. Right? More than or equal to 2 antihypertensive agents should be used in order to achieve the target blood pressure, right? And most of the time, you need to use combinations. Why is that you need to use the combination of the drugs? Whenever you are using the combinations, the dosage requirement of the molecules will be less. When the dosage requirement of the molecule is less, the adverse effects which are associated with the drugs can be reduced. So, preferably it is better to use combination of agents with different antihypertensive mechanisms, right? And whenever you are selecting the antihypertensive agent, or whenever you are combining the antihypertensives, it should be individualized. What all you need to take into consideration whenever you are selecting various antihypertensive agents? That includes, right? That includes, you need to take into consideration the age of the individual, severity of hypertension, other cardiovascular disease risk factors, comorbid conditions, practical considerations related to the cost of the medication, side effect, and as well as the frequency of the dosing. So all these parameters need to be considered whenever you are starting the antihypertensives or whenever you are combining these antihypertensive agents. Now, let me tell you what are all the various oral agents. See, we have a big list of the antihypertensives, right? We have ACE inhibitors, angiotensin receptor blockers, then alpha blockers, then we have aliskiren, that is direct renin inhibitor, then we have beta blockers, then we have both alpha plus beta blockers, then we have calcium channel blockers, then we have diuretics, right? Then we have centrally acting sympatholytic agent like clonidine and all. Next we have aldosterone receptor antagonist, that is your spironolactone and eplerenone. So we have the various classes of the antihypertensives. Among all these various classes of the antihypertensives, what is considered as the first line antihypertensive? Okay, you take any age, right? Particularly because the Indian scenario, let me tell you, in the blacks, and you consider any age of the individual. The first line antihypertensive that will be calcium channel blocker or diuretic, right? Calcium channel blocker or the diuretic. Whereas what is the second line antihypertensive? The second line antihypertensive will be ACE inhibitor or angiotensin receptor blockers or beta blockers, right? Or vasodilating agents should be used. So these are the second line agents. What are the other alternatives? The other alternatives are we have the alpha blockers, right? And we have also alpha agonists. Which alpha agonists? That is centrally acting alpha 2 agonist. So by acting alpha 2 receptors within the central nervous system, that will inhibit the sympathetic outflow. Example is your like clonidine. Okay, right. Then these are the alternatives. And for resistant hypertension, what is the preferred drug? For resistant hypertension, we give spironolactone. So this spironolactone, it is an aldosterone receptor antagonist. So this is the first line and these are the second line agents, right? So these are the antihypertensives that are being recommended.